Good evening and welcome. My name is Jeremy Welch. I'm a GP in Tewkesbury. I'm joined this evening by specialist respiratory nurses Lisa Healey and nurse Anne Williams. We're here to talk about COPD, the respiratory condition, Chronic Obstructive Pulmonary Disease. This affects a lot of people. It affects 1.2 million people across the UK, 2.5% of our practice populations. It is in fact the second most common cause of acute emergency admissions to hospitals in the UK. So 1 in 8 of all hospital admissions are to do with COPD. So it is a big thing and it affects a lot of people. We're coming here from TWNS, Tewkesbury, West Cheltenham, Newent and Staunton. We sit in Gloucestershire. This is a condition that affects our patients, Gloucestershire patients, patients across the country and patients across the world. So the purpose of this evening is really to go through what this acronym, what COPD is, what the symptoms are, who gets it, why they get it. If you've got it, how can we manage it? How can we support you, we as a team, as a medical team? If you've got it, and what are these people talk about, exacerbations or flare-ups? What are they? Why do we get them and what can we do? How can we help ourselves as patients with COPD? What can we do? What can the medical team do? And why is winter the tough time? Why are we here talking about winter and the COPD? So a lot of areas we're going to go through with the specialist knowledge. I'm very grateful for Lisa and Anne's time tonight. So I think I'll fire off with the first question of what is COPD? Lisa.
Thank you, Jeremy. So COPD stands for Chronic Obstructive Pulmonary Disease. Chronic meaning it's a long-term condition. It's not something that comes and goes. When you are diagnosed with COPD, it's there. It's manageable, treatable, but it's not curable. So you've got chronic. Obstructive, there is obstruction in the lungs. Air doesn't flow freely up and down our breathing tubes, in and out of the lungs as it should do. Pulmonary basically means lungs, and then disease, like I said, it's a disease, it's a long-term condition, chronic obstructive pulmonary disease.
And what are the symptoms of this chronic obstructive pulmonary disease?
Symptoms of COPD include breathlessness that has been going on for a period of time. So it's breathlessness that is getting progressively worse over a period of months, sometimes even years. Also, people may have a cough that is becoming more noticeable, so they might be coughing and bringing up more phlegm than is usual. Again, sometimes over a period of time, but sometimes it can be seasonal. So some patients, their symptoms will be frequent winter coughs, frequent winter chest infections, chest tightness as well. So the main symptoms are feeling short of breath, coughing a lot with phlegm, and getting some chest tightness and wheezing occasionally as well. So some patients will feel a wheeze in their chest. Other patients will hear the wheeze in their chest. For some patients, they will be told by other family members that they are wheezing.
So we'll come back to the symptoms in a minute. I think one of the foundation questions is why do we get COPD and who gets COPD? We already know that 1.2 million in the UK, 2.5% of our practice population, but who are these people and why?
And the 1.2 million people in the UK is an interesting statistic because it is estimated by various different lung charities that there are missing millions of people that go undiagnosed with COPD because their symptoms are put down to smoking or old age. Smoking, therefore, is one of the particular contributors to COPD. Most patients who have COPD will have a smoking history, either themselves are smokers or used to be smokers, or they've been exposed to passive smoking over a period of time in their lifetime. Smoking is the key feature for most people. Other symptoms can be exposure to fumes, to particles, to noxious substances, environmental conditions, and exposure to smoke. So we talk about smoking, but also exposure to smoke, open fires, that kind of thing. Those are the main symptoms, not symptoms, causes.
So we talked about cough, breathlessness, chest tightness. I had a nasty coldy bug the other week, and I had all of these things. So have I got COPD?
Not necessarily. So these are symptoms that go on for a period of time. Obviously, we talked about frequent winter chest infections, which people will get better from.
Yeah.
But if you are noticing that you've got symptoms that are getting worse over a period of months, years, not improving with treatment. So, for example, if you have a chest infection and you have some treatment for that, if you're not getting better afterwards, or if you have flu-like symptoms, and again, we might not necessarily treat those, but we give you an expected time frame of when you should start to feel better. And if you don't, then we might start thinking about other potential causes.
So it's the persisting more than months, really,
Yeah.
and I guess recurrent nature as well.
Yes.
And I think we all know people with that persistent cough, and every time they go for a walk, they start to cough, don't they? And actually, they may well be, I don't know, we may see 2 or 3 times as many people with COPD than we actually officially know about.
Yeah, quite often we'll get referrals from other clinicians when they see patients that have come in repeatedly 2 or 3 times, and they'll say, can you just look into this? This is the 3rd time they've been in this year with this chest infection and with chest symptoms, or they've got ongoing shortness of breath when they haven't got an infection. But some people have these symptoms outside of the infective periods, and we'll get referred in to say, can we just have a look?
And we see that pattern, don't we? We've got the medical records here, and as respiratory nurses, you see people recurrently coming in, and okay, once it happened, that's fair enough, twice, but it's that recurring pattern.
Absolutely.
So we know what COPD is, we know what the symptoms are, and we're looking for that sort of persisting symptoms, and we know that a lot of it is lung pollutants, smoking, smoke exposure. There are some sort of products in the air that may cause irritation to our lungs. I guess that the real sort of pertinent question is, okay, let's say I'm a patient, and I have a bit of persisting shortness of breath, and my chest is tighter than I think it used to be. And I think looking back, actually, the last few winters, I have been in to see both of you with chest infections. So I'm a little bit concerned. I've got COPD, and I'm going to book in, and I think I'm going to book in to see you, Anne. So what happens to me when I come in and see you?
Okay, so the first thing is getting an accurate history. So I would be asking you a lot of questions, like for instance, smoking history, family history. How long has this been going on for? What are your symptoms? The duration on what's your triggers? What was your working environment? All of the lifestyle background to begin with. Then I would organise some blood tests. Now the blood tests will not be proving to be COPD, but they will be ruling out other causes for possibly some of those symptoms, like anemia,
Sure.
like the thyroid problem, those sorts of things. So we'd be looking at those to rule those out. The next thing we'd probably consider, if I really was considering whether you've got COPD, I would be asking for a routine chest X-ray. Okay. And I say a routine chest X-ray because I'm not necessarily going to look at this chest X-ray and prove or disprove to have COPD. I would be looking for any other cause, if there's an infective cause. Have you had TB in the past? Is there any other indications on that chest X-ray that could explain these symptoms? We would also do a body mass index, so we do your height and your weight and look at what your weight is doing in components to your symptoms, whether there could be a contributing factor, and your fitness levels. We'd also do an ECG. The ECG would be looking at what your pulse rate is and what your heart rate is to rule out any other causes for some of those symptoms. Given all of that, then what we'd actually do is say, okay, what we need to do now is to refer you on for some lung function tests. Okay.
So we'll come to lung function in a second. So I think it's fair to say, often from a really good history, and we're all guilty but appropriately asking lots of questions, I think probably you get a good feel when patients come in that this may well be COPD. And as you say, the chest X-ray is to make sure there's nothing else that's causing it. The blood test is to make sure there's nothing else that's causing it. And so you get a real feel from talking and understanding the symptoms over a period of time, don't you?
Absolutely. What they are saying is the history gives you 90%. The 10% it will give you the evidence behind it. But you're there, you diagnose predominantly on history.
So I've come in to see you, Anne, and I've my history is quite suggestive of COPD, and you're suspicious I have some COPD. I was a smoker in the past. I have been coughing and spluttering a bit more than I feel comfortable, and family have commented I've been coughing a bit more. I've had a couple of courses of antibiotics for my chest over the past few years. My chest x-ray is clear. There's nothing else that's obviously causing my shortness of breath, and my blood tests are good. My ECG is good. I'm pleased with that. That's good. And then you touched on lung function. So if I come to you, Lisa, to talk about lung function, or sometimes we call it spirometry, don't we?
Yes. Spirometry or lung function tests is done usually after all the other investigations that Anne has mentioned, because spirometry confirms the diagnosis. So like you said, we've already got a high suspicion of COPD in these patients, and so we then perform spirometry. Spirometry is usually done at the surgery by one of the practice nurses or myself here at this surgery, and it involves an extended appointment. It takes quite a bit of time, usually between 45 minutes up to an hour for that appointment. And what these lung function tests involve is basically huffing and puffing into a machine. So we have a machine which has tubes attached to it, and we will get you to blow forcefully into this tube as hard as you can for as long as you can, and the machine will make accurate recordings of what it measures. And we can use these measurements against variables such as your height, your age, and your gender.
I was already quite short of breath when I came in to see you. Is it manageable? I mean,
it definitely is manageable. It will make you a little bit more out of breath,
okay,
but we don't do it too intensely. And it is a test that you're doing when you're sat down. So you're sat down, you're taking a big breath in, and you're huffing and puffing out into this machine.
So do I need to understand as a patient the technicals of this? Well, what's my spirometry showing me? What are you looking for in it?
So we're looking at how much air you can blow out of your lungs in that first second. So when you're really going for it, and most fit and healthy people should be able to get at least 70% of their air out in that first second.
Okay.
If you are not able to blow at least 70% of your air out, then we tend to say that your lung pattern is obstructive. There is something that is stopping you getting that air out as quickly as you need to. It may be that you breathe out for a longer period of time afterwards, but there is something just not quite right in the lungs. They've become a bit constricted, they've become a bit tight, so your breathing isn't flowing as it would do normally.
Okay, so I've come to you with my symptoms. You suspect I've got COPD. My tests so far are normal, but my spirometry test is not great.
Mm-hmm.
Okay, so what happens to me now? What are you going to do to me now?
So when we have the results of these lung function tests, and I'm just going to go back and say, because I mentioned it was an extended appointment, as part of this appointment and you're blowing into the tube, you may well be given an inhaler as part of this test to see whether your lung function improves after you've used that inhaler. So you'll be huffing and puffing into a machine, you'll have some puffs of an inhaler, you'll wait 10-15 minutes, then you'll come back and you'll have a bit more of the huffing and puffing done. Depending on what your surgery does, you may be given a diagnosis there and then. And if you come into Myers Medical Practice, that's the way we work. You have the lung function test done, you get given a diagnosis there and then, and often you will be started on some form of treatment.
But in some surgeries, the patient may go away and then doctors and nurses meet,
yes,
have a discussion. And
some surgeries, people who do the spirometry tests won't interpret the results. So some surgeries, okay, you might not get them straight away.
Okay, so if I had it and no one said anything, that doesn't mean it's disastrous.
No.
Okay, fine. Okay. So I've done my spirometry and I've done my reversibility, and that's going to be key. We're going to talk about reversibility and the blue inhaler in a bit, aren't we? So tell me about, I've let the cat out of the bag there, but tell me a little about what happens next to me when I've got COPD. You've confirmed it on the spirometry.
So we will want to see if there's any lifestyle factors that we can address to help you manage this condition better.
Okay, I think this is your field, isn't it, Anne?
Yeah, well, we've got some real goals here to manage COPD, and the first one is early diagnosis and try and get it as accurate as diagnosis as we possibly can. The second way is the best way to control symptoms. So looking at the not only just inhaled medication, but lifestyle changes. And the first thing around that is to stop smoking. If you are a smoker, the number one thing you can do is to stop. Okay. And the second thing is to avoid smoking environments. Getting better in the UK because we're now much less places that we can go and smoke. So it is getting better. The other side of things is there's several other areas that we can do.
So smoking cessation, they can access help through Healthy Lifestyles Gloucestershire, through practices as well,
and
pharmacists, absolutely. So stopping smoking is the key. We've right at the very beginning, we talked about most COPD is related to smoking damage to lungs, isn't it?
As I said when we were looking as part of your history, we do your height and weight and your body mass index. This is really important for managing symptoms as well, because if you're carrying too much weight, we would be encouraging you to address that issue, because if you're carrying too much weight, you can get more short of breath and you'll be less able to do activities, because activity is the second biggest thing that we can actually encourage you to do to improve your symptoms.
And I guess here's that question is that I've come to you, I'm short of breath, and you're going to tell me to do exercise. Well, I'd love to be doing exercise. So where's the pitch?
Okay, so exercise and getting fitter, as I call it, not just exercise, has maximum benefit with COPD.
Okay.
So the first thing, it improves your heart function. Okay, it improves your muscle function, so you've got more ability to actually undertake your daily activities. It actually improves your well-being, because we release some endorphins in our brain when we actually exercise, particularly if we've done something that's new to us and we've achieved it. These happy hormones get released, which can improve our mood. The other side of it is, as we get fitter and fitter, we have built up resilience to becoming poorly with COPD, because we're actually able to do things more. So if we get a flare up, as we'll talk about later, and we get a problem, we actually have more capacity to deal with these.
Okay. So we definitely want to stop smoking, and we definitely want to help you stop smoking. And there's lots of resources to help people stop smoking. We want to look after ourselves and do a bit more exercise, looking at diet and what we put into our body, and sort of almost looking after the engine and our muscles, our breathing muscles. What else can we do?
Well, there's other coping mechanisms that we can teach people to do when you have your annual reviews. Your annual reviews are really important, because there's other techniques that we can show you. Mechanisms to help with relaxed breathing. So rather than go, to say, as you say, I can't do something, we teach you to sit down, relax, and control that breathing under situations where it becomes a problem. We can help you to show positions that we can help you to manage any excess phlegm that you've got. So there's special techniques there that we can help you to manage this cough, manage this phlegm, this sputum, so that it becomes easier and more manageable.
So managing breathing is really important, isn't it? Because naturally it's scary when you can't catch your breath.
Absolutely.
And actually almost sort of stopping that panic and slowing your breathing down sounds like the thing sort of my gran would have told me, but it absolutely works, doesn't it?
There's a thing called the panic hand. I don't know if you've ever heard of it. So the panic hand is called the panic hand because you take hand with you. Okay, so your hand's with you everywhere, and it teaches you to relax your breathing and to actually get yourself out of a panic attack.
Okay.
I use it in lots of patients who've got breathing problems, but I also use it in anxiety. So the first thing is you hold your thumb. So you've got the symptoms of panic, you know what they are, you're getting the chest tightness, you're increasing your breath, you're feeling a bit breathless, and you're feeling a bit sweaty. So you hold your thumb, you say, it's okay, I've got this, I know what it is. Simple, easy. Then you hold your your index finger, and the first thing is you sigh out. Now it's a big, instantly you drop your shoulders and you're also starting to relax. Your middle finger, so you hold your middle finger and you could breathe in through your nose for the count of 3. So you hold that, and then you breathe out for the count of 4. You repeat that several times, okay, and you're automatically starting to slow down your breathing. And then the last one, you get to your little finger, you stretch out your hand and you think, actually, I've got this, I'm okay. I use this method quite frequently with people because it actually does work. But the best thing to do is to practice it when you're well.
Yes.
So that you can know.
So I'm working on stopping smoking, or I've stopped smoking. I'm looking after myself and doing a bit more exercise. I've had some techniques for if I do get myself in a bit of a pickle and I'm getting short of breath. What else can I do for myself, or can we help with COPD?
Medication,
including vaccinations.
Mm.
Vaccinations are really important. They're a way of stopping us getting these illnesses, these diseases. And for people with COPD, it's really important that you get your flu vaccination every year. So having COPD will automatically qualify you for an NHS flu vaccination. For some
Every year?
people,
I had it last year. Do I have to have it again?
Flu strains vary every year, and the flu vaccine that you're given will be slightly different to treat those expected strains. So yes,
Okay, so
flu vaccine every single year. We also offer COPD patients a pneumonia vaccination. This is a one-off vaccination. It's not always given in the winter months. It can be given at any time in the year. It's one-off, like I said, and it will protect you against 23 different strains of pneumonia strains.
Sounds great to me. A one-off injection, cover me for life, and covers 23 different types of infection.
Yes. The new vaccine which people are talking about this year is the RSV vaccination. So that's another respiratory illness. Not everyone with COPD will be eligible for this vaccination. At the moment, it's based on age. So we are giving that vaccination to people aged between 75 and 79 years old, and also pregnant ladies to protect their unborn babies from getting this respiratory illness when they are young. So if you're called for it, absolutely have it. If you're not called for it, don't panic that you're missing out.
Yeah, it is that window. It's 70 to 79 at the moment, and pregnant.
Also COVID.
Yes,
COVID.
absolutely. We can't forget COVID. And so I guess it's my adage about having the flu vaccine every year. COVID vaccine is slightly more than every year at the moment, but absolutely these are new strains that are coming through, and we do need to keep up to date, particularly with people with COPD who have
because they're respiratory illnesses. Flu, COVID, the RSV, they are respiratory illnesses. So if you already have a respiratory condition and your lungs are not working quite as well as they should do, then if you get these respiratory illnesses on top, you're going to be even more susceptible to worsening conditions.
So these are insurance policies, aren't they? This is so it's my flu every year, it's my pneumovax once in a lifetime with COPD, it's my COVID vaccinations when I'm invited, and the RSV, rhinosincitial virus, if I'm 70 to 79 or pregnant.
Yes.
So vaccinations, absolutely recommend. Prevention. Okay, so we've looked after ourselves. We've had our vaccinations. Can we talk about medications yet?
Absolutely. So medications. People with COPD will have medications, most notably in the form of inhalers. The reason why we mention all the other things you can do first is because those things have been shown to have the biggest impact on managing your disease. COPD is manageable, but it's not curable. We can't cure it. If you have COPD, you have it. But we want to manage it and prevent it from getting worse if at all possible. So we will give you medication that you can have yourselves to treat it. And a lot of people have two different types of inhalers. Most people have heard of blue inhalers. Blue inhalers are traditionally your reliever inhaler. And a reliever inhaler is one that is quick acting, so it works to relieve your symptoms that you're getting, often within minutes, but it is short acting as well. So a lot of the time they will only last for a few hours. So your traditional blue inhaler is a quick acting but short acting reliever medication that works directly on the lungs to relax the muscles, open up the airways and make your breathing easier. We also have preventer inhalers. So whereas reliever inhalers are on an as and when basis, you take them if you need them. If you don't need them, fine. Preventer inhalers are to be taken every single day, regardless of symptoms.
Every day?
Every day. Some people have once daily inhalers, other people have twice daily. So it's important that you know which yours is, so you're taking it as and when you need to. And again, there's different types of preventer inhalers. So some people will have a preventer inhaler which has long-acting reliever medication in it. So similar to your traditional blue inhaler, but it's longer acting, so it will last 12, 24 hours, depending on which type of inhaler you've got. Other people will have an inhaler which has got that long-acting reliever medication in it, but it also has an inhaled steroid as well. And these preventer inhalers are absolutely vital to prevent you from getting the symptoms. So that's why we say they must be taken every single day, even if you are feeling well.
And there's lots of different types. It's often a moving world, isn't it, with inhalers? And so that's why we encourage annual reviews with your COPD, because there are newer versions and more convenient versions and better acting versions. And so absolutely, with patients with COPD, when you're invited for your review, absolutely, we want you to come in, because there's sometimes better things around.
And not all inhalers work in the same way. So there's hundreds of different types of inhalers, and there are so many different ways to take them. But it is important that we make sure you're using your inhaler as correctly as you can to get the medication delivered as we want it.
So I've stopped smoking, I've exercised and lost weight, I'm looking at my diet, I've done some coping breathing. I've absolutely taken that on board, the hand you talked about. I have had my vaccines, loads of them. I'm using my preventer inhaler every single day. When things are going well, I don't seem to need to use my reliever inhaler.
Perfect.
And so things are going well, but they don't always go well, do they? And so I think we need to talk about that. That's in an ideal world when things are going well. There are bumps in the road, aren't there, with COPD, and we call them flare-ups or exacerbations, don't we? So
absolutely.
Should we talk a little bit about those and what causes those and what we do?
Okay, so an exacerbation or a flare-up is a sustained worsening in a patient's condition. Okay. It is variable from their day-to-day condition. Okay, so it's outside of that. So what you can do normally day-to-day, that's day in, day out, doesn't change generally when you've got COPD. But when you've got a flare-up, it's acute onset, and it really does necessitate a change in treatment or management.
So what do I feel as a patient? How do I know?
All the symptoms that you can get,
Yep.
which you can come in with for diagnosis, so shortness of breath, cough, wheeze, lethargy, chest tightness, increased sputum. All of those can also be the signs and symptoms of a flare-up, okay, but with a difference. Okay, so if you've got a cough and your cough's usually in the morning and it usually lasts a couple of hours, but suddenly you've got a cough and cold that's getting prolonged throughout the day, and that's not normal for you. You cough up mucus normally, but it's changing. Okay. It's actually dirty, it's going brown. That actually necessitates a change. You could be somebody who never ever gets wheezy, never gets chest tightness, but these symptoms necessitate a change, not only in treatment, but also in your management.
So I've had a bit of a change in one of my things, whether I'm a bit more short of breath, or my phlegm's gone a bit mucky, or I'm feeling a bit tighter in my chest generally as I try and expand my lungs. Okay. What do I do then? Okay, so it depends on the cause, and we don't always know what the cause is of an exacerbation. It can be viral, it can be bacterial, it can be pollution, it can be weather changes, and sometimes get it for no reason. Yeah. It just happens. So what we actually say is look at how many symptoms you've got. All right. So if you have one of those symptoms, say you get a bit increased breathless or you get a bit increased cough, and we'd say, first of all, maximize the use of your reliever inhaler. So that's where that comes into play, isn't it? That short acting, quick onset reliever. So we'd say start with that, and if yours prescription says 1 puff 4 times a day, then that's what you would do. If your prescription says 2 puffs 4 times a day, that's what you would do. Okay. So we would start that, and we'd start it quite quickly. Yep. So we try and get on top of this. If it tends to be viral in nature, that's usually enough. We often don't need to do anything else, and that will do 2 or 3 days, and we feel back in control. So the single sign, I step in with my reliever inhaler. I have dusted off. I haven't used it for a good few months because it's been waiting and I've been doing well.
Absolutely.
I start using that 4 times a day, and actually I'm starting to feel a bit better. So I can then step back. I'm all right.
Yeah, absolutely. But making sure you're taking your maintenance
Yes,
preventive
keep going.
inhalers. If you have more than one of those symptoms and you're starting to feel unwell, okay, it's really important that you keep you do your reliever and you keep a real close eye on yourself. So if symptoms are getting worse over 2 to 3 days, we'd like to either you'd be contacting the surgery to say, okay, this thing, I've got these symptoms, they're not my normal, I'm not beginning to feel unwell, my sputum's changed, it's really thick, it's really dirty, you know, what do I do? So you seek attention from your GP practice or your respiratory nurse. And over the weekend, if you are poorly and the practices are closed, we don't want you to wait till that Monday morning. It's really important that you act and that you phone in.
But they're your favourite patients. Surely you want to see them on Monday.
I will want to know about them on Monday. Okay. Absolutely.
But I want to know that they've sought some help.
Absolutely. Yeah. And that they've got, if they've needed antibiotics, that they've got them on board. If they've needed steroids, that they've got them on board. I'd like to know so that if this is outside of their norm, and then we can do a review, we may need to change their long-term treatment as well. Yeah. We may need to step it up. You know, everything varies from patient to patient.
So one symptom, absolutely, we step in with our reliever inhaler. If we're getting to 2 and we're starting to feel poorly or unwell, that's when we're calling GP surgery, respiratory nurses, 111, and we're reaching out for help.
Absolutely.
And then what would we do as a team? What would we offer to our patients in those situations?
There's several types of treatment. So sometimes we would, we'd just listen to the chest and say, actually, this is viral. Okay, we don't need antibiotics. Sometimes if their chest can be really tight, we could be saying, actually, we probably may need some steroids here because it's really tight and your intake is reduced and you're struggling with just the use of the inhaler. Okay, we might need that. Some patients we may need to give antibiotics and steroids. Okay, so the antibiotics to get rid of an underlying infection and the steroids to help relieve any inflammation and help those airways relax and to open up a bit better.
And some of our patients actually have, we often call them rescue packs or steroids and antibiotics at home, and some of our patients don't. Should we just explore a little bit why we've got that discrepancy?
Okay, so the discrepancy comes from several areas. So first of all, this may be your first exacerbation, your first flare-up. You don't know how to manage that, but you do know you need to seek attention. Yeah. So that's number one.
And actually, you won't automatically get given a rescue pack on diagnosis.
Yeah, because you said that actually some people you'll see with an exacerbation and actually say you're doing the right thing. Stick with your blue inhaler.
Absolutely. Secondly, some patients we know that from their history, as you quite rightly said earlier, Jeremy, we've got all their notes in front of us. They repeatedly have flare-ups.
Yeah, you can see a pattern, can't you?
And they've ended up in hospital before.
Yes.
And we want to avoid that as much as possible. These patients who are very aware of their symptoms, very aware of their management plan, very, very sensible and able to know when to start treatment, they're given antibiotics, steroids, we call it a rescue pack to keep at home, with clear written instructions of when and how to start them, but also clear instructions to let us know that they've started them. For several reasons. One, we want to know they're getting better. 2, we want to review their situation and make sure that we don't need to step up or step down or do alternatives. And 3, we also may need to replenish that pack.
Yeah, so I think the message is if you are someone who's got that pattern that recurring and you have in your COPD review been given them, we want you to call your surgery regardless, because we want to know, don't we, as a surgery? And like I say, if you started a pack, you'll need it replenished just in case you went back to back and had 2 flare-ups back to back.
Absolutely.
We don't always win, do we, with our antibiotics and steroids? So there are cases where things can exacerbate, and absolutely, we already talked at the beginning, didn't we? That 1 in 8 of the emergency admissions in the UK to hospitals are with COPD. So things can escalate, and I think the message will be that steroids help if given, antibiotics help when they're given and when they're indicated. But if things are getting worse, what do we want then?
Again, we want them to contact us. So steroids often given to help with the breathlessness, that acute worsening of getting short of breath. And steroids, oral steroids, prednisolone, will usually help to ease that within 24 hours of starting them. Antibiotics can take a little bit longer to work. They can take 2 to 3 days before they really kick in and you feel the benefits and you start to feel better from that yucky unwellness. But again, you should start improving.
That's good to know, isn't it? Because I mean, I guess if it's my first exacerbation, and I've heard about these steroids, obviously, and I think I might hope they work really quickly, but it's sort of about 24 hours really to start to kick in, isn't it? And it's good to know. I mean, if you were someone with COPD and you've had it for years and years, you'd know your COPD probably almost better than we know your COPD.
Yes. And I think the key thing is, like you say, we don't always win. So if you are not improving within those timeframes, or if you are getting significantly worse, if you're finding that you are breathless at rest when you're sat down and you're not doing something, but you're struggling with your breathlessness, you can't talk in full sentences like we're doing now, that's quite a red flag that we need to know about. If you're getting some sharp chest pain, again, that's not your normal, we need to know about that. Those are definitely worsening signs, and you should have advice on what to do with those worsening signs, be that you phone up the surgery for an on-the-day appointment, you're phoning 111 for an out-of-hours appointment, or sometimes even you are taking yourself to A&E or ringing for support to get yourself to A&E.
So questions come in from Anita. Can you get a rescue pack to take abroad with you? It's not a straightforward question, this one, is it?
No, but yes, within reason.
Yeah.
We don't give out rescue packs just randomly. It's something we would want to have a discussion with you about to make sure that you are using them appropriately, but also, again, to make sure that if you take your antibiotics and you're abroad and you're not improving, you know that you have to seek further help, because they're not always the miracle cure we want them to be.
So it's it is really a case by case, isn't it?
Yes.
So and so if Anita, if you were going on an Arctic exploration, absolutely you'd have some rescue pack available with some very clear guidance. But I think if you were going to France or Spain and to sort of major areas with medical help around, and you hadn't really had many exacerbations before, we would much rather you sought medical help just to make sure we're doing the right thing and it's not something else that's causing your shortness of breath. There is that real feeling about, as I talked about before, about knowing your COPD. Once you really get to know it, you know the telltale signs. I'm going to come in with stage 1 with my blue inhaler. It's working good, or it's not working. I need to step up. So it's a real case by case to be discussed at your COPD reviews.
Yeah, or if there's something you're thinking about, well, I'm going abroad in 2 months' time and I'm a little bit anxious, should I take some? Then absolutely, it would be worthwhile making an appointment to see your COPD nurse about that. One other thing we want to make sure with antibiotics is we talk about appropriate use of antibiotics, because if you are having repeated courses of antibiotics, it might not be the right antibiotic for you. Your body can become resistant to certain types of antibiotic, so you may need to go on a different type of antibiotic. But again, it might not necessarily be COPD. We might need to investigate other causes, like we've said, and sometimes we will want to do things like get a sputum sample, send it to the labs, check what exactly is growing, we're treating it correctly, or whether there's other respiratory diseases that are coming into play here as well.
Or other causes, for instance, might need to do a chest x-ray, we might need to do blood tests, might need to have a look again.
Yeah, so I mean, there's almost a sort of conveyor belt for exacerbations, but everyone's a little bit different and everyone's COPD is a little bit different, and so we've just got to keep a very open mind, haven't we?
Well, just because you've got COPD doesn't mean you can't go on to develop other conditions, and that's you also need to be mindful of.
So we're talking about winter. We're here sort of coming up to winter. The weather, the evenings are coming in, the weather's getting a bit more inclement and a bit colder, and we're talking about the problems with winter and why winter is not naturally the best time for COPD and what we can do to counteract that. So do you want to talk about that?
Okay, so we talk about staying well in winter with COPD. So why is winter an issue? Well, winter generally people stay indoors. So we mix, you know, and children, for instance, are very good at spreading their coughs and colds.
It's good to share.
And their viruses. You're not the best at cleaning their hands, so we're all at risk of spreading everything inside. In the summer, we tend to be a little bit better because we go outdoors more. So we're more at risk in winter for that reason. So that's the first thing. So we need to be, first of all, mindful of the weather, mindful of where we are. Mm-hmm. The second thing is in terms of the weather, we know from history, we know from the Met Office did studies in recent years about the effects of the cold weather on respiratory conditions, not just COPD, but also with asthmatics and also patients with heart failure, that the cold air can exacerbate breathing conditions. So what they recommend is, the first thing is when you go out is to making sure that you wear the appropriate clothing.
Okay.
I'm not talking about thousands of clothing, but there's a couple of things that are really pertinent. So a really good coat, so it keeps the wind
latest
out.
Brand.
No, doesn't have to be the latest brand actually. It just needs to be effective. The second one is a hat. We lose a lot of our heat through our head.
Yeah.
But the most important one is you're wearing a scarf. When we say using the scarf, and we're not talking to wrap around your neck, we're talking to put over your nose and your mouth. The reason that's really effective is because if we then breathe the air in through the scarf, we're warming up the air as it goes through our nose and down into our airways. What that does is reduces the effect that the cold air can have in further reducing our airways and constricting and making them more obstructive.
We can all feel it, can't we, when we go out on that cold morning? It feels a bit tight, and naturally, if you've got COPD and you're a little bit tighter day to day anyway, it can be enough to tip things over, can't it?
Yeah. The other thing is, if we're being mindful of the weather, we know there's a real cold spell just about to come in. Check your inhalers, check your medication, make sure you've got enough stock in. If you know that it takes 5 days to get it from whichever way you order your prescriptions, and there's multiple ways, but whichever way, making sure you know it takes 3 or 4 days, that you've got enough in.
There's a bit of planning, isn't there, for winter? We know there's bank holidays over the winter, Absolutely. The Christmas period, the New Year period, when not all the chemists are open and the surgery may not be open. So there are different ways that we can stock up on our medication, order medication. Some people order through the pharmacy, some people order through the surgeries, some people order and have it delivered online. And the one that we like to promote is the NHS app, where actually you can see your medical records. You can see which inhalers you're on, you can look at what tests you've had, and you can order your medicine through the NHS app. So we encourage people to download the NHS app from the App Store. Some
of the simple things to do is making sure that you're keeping warm. Okay, so you're keeping your home warm. I know that's a big issue for some people at the moment, obviously with our pensioners who we know we got in this reduction in their benefits. But there are avenues where if you are really struggling for finances, you can go to seek advice.
Where do you recommend?
Well, there's the Age UK are particularly good. There's also our social prescribers within the surgeries, and the libraries tend to have an awful lot of warm space there and lots of information there as well. So there's lots in the community.
Citizens' advice, people can use as well, and often contacting your energy provider. It's definitely worth doing if you are struggling, and we know a lot of people are financially on the edge of do I heat or do I eat? It's that conversation, isn't it?
Absolutely. But the other side of that is making sure that you're drinking warm drinks. Warm drinks will help from warming from the inside. Try to make sure your bedroom you're not going into a very cold bed. So hot water bottles are good. Be cautious with them, make sure they're in the proper covers, and make sure that they're actually still in good condition. So those sort of things. And then we go back, we're reverting all the way back to the beginning. We said one of the biggest things that we could do to improve our condition is exercising. Exercising can actually keep us warm.
And you're always going on about exercising.
I know, but it's really good. And it can also, as I say, it improves the strength of the heart, it improves our resilience, it improves our muscles, so it is really important. And just if you're feeling unwell and the weather is bad, stay indoors.
Yeah.
Just try and restrict the amount of times you have to go out in it.
It'll get better. The weather will improve.
It will.
Conserve your energy and don't spread your bugs to others.
Yes, and so that's the problem, isn't it, with winter, isn't it? We all think about the sort of cold weather causing cold. It doesn't, does it? It's just the fact we're all in together and we're sharing them around. So goodness, we've been through a lot tonight. We've been through what is COPD. We've been through what are the symptoms of COPD. How do we get COPD and why do we get COPD? How can we investigate COPD and how can we manage COPD? We talked about exacerbations and your reliever inhaler and some people have rescue packs, but absolutely contacting the surgery or NHS 111 if you're worried or your symptoms are exacerbating. And we talked about that 2-stage, didn't we? The first stage, that's your reliever. Second stage, if things are not getting better or getting worse and you're getting the additional symptoms, that's when we call for help. We talked a lot about how we can help ourselves. We talked about the exercising, not running marathons. This is about going for more walks, using these muscles, helping our respiratory breathing muscles just as we would our legs and our arms for exercise.
And recognising that being out of puff is not always a bad thing. Getting a little bit out of puff with exercise is good.
Absolutely.
We talked about the protection of the vaccines, and absolutely it sometimes feels like there's a lot of vaccines that are being offered, but we are offering for the right reasons because we want to protect those lungs, because you are at more at risk with COPD. We talked about the role of inhalers, the regular rain or shine everyday preventer inhalers, and then the reliever inhalers for when we've got exacerbations or symptoms. We talked about ordering medications. We talked about some of the relaxing breathing that's sort of very simple, almost before the sort of the reliever inhaler, using some of the coping breathings because it can be scary when we can't catch our breath. So I think we've covered a lot of things tonight, and I'm really grateful for your time, Lisa and Anne, for here. And I know winter is going to be a busy time for you guys because there will be exacerbations, and absolutely we want to hear from patients if they're worried and if they're concerned. So thank you again for your time tonight.
Yeah, I've got a question.
We've got another question, have we?
We've got a question about long-term steroid use.
Yeah.
From someone who's had COPD for 30 years, is actually waiting for surgery to take away a portion of the lungs, which is a possibility we haven't mentioned tonight, but that's a long way down the road for a lot of people. But this patient is mentioning that she's got brittle bone, she's got thin skin, so concerns about long-term steroid use. And I think the key thing to address there is that there is a big difference between inhaled steroids that you are inhaling, that are working directly in the lungs, and all steroids, so all steroid tablets. Generally, the inhaled steroid component of your inhalers that you're taking for COPD are a relatively low strength of steroid compared to steroid tablets. And what we're trying to prevent is you needing all steroid tablets, which can go on to have adverse effects. My take-home point here would be don't stop taking your inhaled medication, whatever it is. But if that's something that you are concerned about, talk to your COPD nurse, talk to your GP, because like I said, the concerns with inhaled steroids, there's not so much a concern there as with long-term oral steroids.
I mean, it's relatively, the inhaled steroids are into our lungs, they're lining the inside of our lungs, and a minuscule amount will get in systemically into our bloodstream. Now, as COPD and respiratory nurses, we're almost trying to get people on the lowest dose of medication we can to keep them safe. It's a very sort of fine balance. You sort of you have to strike on this one.
And everything does have side effects, and as we get older, our bones do become more brittle, our skin does become more thin. So again, it is a balancing act. But there are things that we can do, there are things that we can talk to you about. And as we've said before, every person is different, but definitely something to talk about at your annual review or sooner if necessary. Okay,
I was going to see if there's any more questions coming in. But that's a really good question, just because that is something that comes up, isn't it? Regularly, people worry about steroids, worry. But actually, the inhaled steroids we will maintain on the lowest dose that keeps people well and reduce the exacerbations. So thank you again. there is a little bit more, particularly for our Tewkesbury patients, Tewkesbury, West Cheltenham, Newington, Staunton patients. As a follow-up to this event, each of our surgeries, so that's Mythe Medical Practice, Church Street, Staunton Surgery, Newent Surgery, and West Cheltenham Medical Surgery, want to do a one-off COPD evening where our respiratory team will be available. It will be on Monday the 28th of October at Mythe Medical Practice between 6 and 7 o'clock. It will be on Tuesday the 29th at Church Street Surgery, 6 to 7 o'clock. It'll be Wednesday the 30th of October at Staunton Surgery, 6 till 7 o'clock. It will be at Newent Surgery on Thursday the 31st, so that's 4 days in a row at 6 till 7. And then a week later on Wednesday the 6th of November at West Cheltenham Medical Practice. So all of these events are from 6 till 7 p.m. We're encouraging people with COPD who have got more questions, more concerns, to use this as a drop-in. Although I use the term drop-in, we would like people who are going to attend from 6 o'clock, because there will be a presentation initially for some people, that either sort of revision of what we talked about tonight, or for those people who haven't managed to attend or been recommended, just a sort of catch up of where we are. We will have respiratory nurses available for more questions and discussions. We will have the opportunity to catch up with any vaccines that you may not have missed, and if we may have sort of pricked your ears and reminded you about the importance of vaccines. We will have time for people, any sort of personal questions I wanted to ask a little bit more. We will be joined by a selection of partners as well, an organisation called Warm and Well, to look at what resources locally we've got to help people with the challenge of paying the winter fuel and keeping the house warm enough, and giving advice, support, guidance of where to turn. We will have some support from our pharmacy team, our pharmacists. We have in-house pharmacists talking about medicines, and we will also have our health and well-being team. So really encourage people, particularly if you've realised you've missed your vaccines, and I know sometimes it's hard. We talked about all the vaccines that we offer as part of the insurance to keep your lungs well. Absolutely use that as an opportunity. And if you've got more questions, please do pop in and meet the team and say hello. Each of our member surgeries 6 till 7 p.m. So Mythe Medical Practice, 28th of October, Monday the 28th. Tuesday the 29th, 6 till 7 at Church Street Surgery. Wednesday the 30th at Staunton Surgery. Thursday the 31st at Newent Surgery. And Wednesday the following week at 6 till 7 which is the 6th of November at West Cheltenham Medical. So thank you very much for listening, and thank you again for giving up your time, Lisa, and thank you so much.
Thank you.
Thank you.
Thank you.